Good evening, everyone, and welcome. My name is Beth Anderson, and I'm the Executive Director at Hill Learning Center in Durham, North Carolina. And I'm thrilled that you are joining us for our second event in our community education series this school year. For those who aren't familiar with Hill, we're a K-12 education nonprofit that exists because mainstream instructional practices too often do not serve all students, including those with both diagnosed and undiagnosed learning differences and attention challenges. Our ambitious vision is that all students with learning and attention challenges receive the instruction and the support that they need, regardless of where they attend school or whether they have a formal diagnosis. And we pursue this vision through a range of student and educator programs and knowledge and field building efforts that reach students and educators in Durham, across North Carolina, and beyond. If you haven't already, I strongly encourage you to check out our website at hillcenter.org. Through this free community education series, we aspire to offer practical research-based strategies to help students, as well as the parents, teachers, and professionals who support them. We attract parents and educators and professionals from all over the world to these sessions. And we typically have a mix of folks with strong ties to Hill and those who are not. So wherever you are coming from, and whether this is your first community ed or you're a regular, I welcome you this evening. Before introducing our speaker, let me cover just a few housekeeping details for this Zoom webinar. This session is being recorded and will be sent out tomorrow along with a short survey. Please complete the survey. Your feedback is important to us in developing future sessions, and we really do look at that and take that into account. There is also a link to the slide presentation in the chat, and we'll update that periodically. And the slides will also be included in tomorrow's email, so you can really focus on the presentation this evening. All of our participants are muted, but you can submit questions or comments to the presenter and the Hill team at any time using the chat, and I encourage you to do so. We will have a moderated Q&A at the end of the session, and we'll be drawing on your questions from the chat in order to ask questions of Dr. Riddle. You should know that the chat is only visible to the presenter and the tech support and our support team here. So you won't see it, but we will be monitoring it throughout. So thank you again for joining us. And now it is my distinct pleasure to welcome Dr. David Riddle. Dr. Riddle is a licensed clinical psychologist and president of Chapel Hill Pediatric Psychology. He has more than 20 years of experience in pediatric psychology, particularly in the field of attention and learning disorders. I have a strong personal affinity for David, as not only was he head of the search committee that hired me at Hill and my very first board chair, but he has also evaluated my son twice and advised him and us on our own journey seeking accommodations and supports, choosing schools, and parenting a child with learning differences. In addition to conducting comprehensive psychoeducational evaluations, Dr. Riddle provides children, adolescents, and adults with cognitive behavioral treatment around issues pertaining to the challenges of ADHD, and he frequently conducts all kinds of workshops and presentations for schools and community agencies on ADHD across the lifespan. We are so lucky and grateful to have him as part of the Hill community and with us here tonight to share his expertise. So with that, let me turn it over to David Riddle. David.
Thank you, Beth, for those kind words and the opportunity to join you tonight. And let me also extend a welcome to those joining us this evening. Whether you're here to confirm your own hunches or to disconfirm a comment made by a teacher or family member, or simply curious, I hope I can shed some light on the question of what is normal adolescence and what may be ADHD. A question that I hope to untangle for you this evening. As we begin, I do believe it's important to acknowledge at least two issues. The first, I'm going to reframe our discussion with a redefinition of the task before us. I would prefer to use the term typical rather than normal. So I was given the title, and I worked around it, but I want to change it to typical. Secondly, I believe it's important to acknowledge a reality that has complicated this question to a significant degree about what's typical and what may be a disorder. Let me just assure you there is no political, nothing political about calling this the elephant in the room. I think it's important as we talk about this issue to understand the role that the pandemic and the subsequent challenges have had on our kids. And it's uncovered issues in our children and adolescents that may not have become uncovered until much later, unfortunately. Specifically in practice, I've seen good students otherwise present with executive functioning issues that have left themselves and their parents and guardians scratching their heads wondering what's happened. While we may be returning to a new normal of sorts, I believe it's important to understand the profound impact social quarantine and virtual learning has had on our children and adolescents, and that it complicates the question of what is typical and what is a disorder. For our adolescents in particular, the lack of social interaction with peers and the loss of milestones was profound to their emotional well-being and continues to be so. So that being said, let's begin. Here are things that I frequently hear in my first conversations with parents who come for an evaluation. Probably the first one, the most I hear is, he's all boy, it's not ADHD. Or, she's gifted, she's just bored. The work is not challenging enough. Or let's blame the teacher. The teacher doesn't have control of the classroom, that's the problem. Sometimes I hear video games have caused his or her attention to be worse. More frequently lately, hearing that he or she can't focus because of anxiety. And the one in the middle, along the lines of the apple doesn't fall far from the tree, I couldn't pay attention myself and I turned out okay. What's the big deal? Okay. So while all of those statements may be true about a student, they don't rule out a diagnosis of attention problems, I must say. And over the next hour or so, I'd like to spend time talking about what might constitute ADHD and what might be typical behavior. So I think it's important to understand our children and adolescents are more than a diagnosis or a character trait. We need a bigger picture or model to understand their behavior. So often I have talked with students in my office to say, you know what? You are more than someone who doesn't turn in their homework because that's how they get defined. So to take a look at that picture, what I would like to do is bring to mind the BioPsychosocial Model for understanding behavior. And this was a framework first proposed by Engel and Romano in 1977 to recognize each person's set of characteristics that promote health and psychological well-being. The model was forward-thinking at the time because it introduced psychological and social factors in the health and mental health behaviors of people rather than a sole focus on the biomedical side of things. So within the circles, we have biology. And this is a short list, there are longer lists, but we're looking at genetic predispositions. Within this area, we look at birth history. We look at a person's medical status and their medical history. And yes, for adolescents, we're looking at their puberty status. We'll talk a little bit more about that later. Within the psychological realm, we take a look at their intelligence, their neuropsychological profile. We're looking at their emotional health or any mental health diagnoses, looking at trauma history that may be complicating the current presentation. And socially, we look at, does this person have access to adequate income, housing, and food? What's the family structure like? Who's present in the family? What are those dynamics like? What kind of social supports does the family have in the community? And what kind of educational opportunities does the child have? So, for example, in the light green area, and I don't have a pointer, but you can see an overlap of psychology and sociology. We have the impact of parental mental illness on a child's behavior. We look at the orange area, we have lack of affordable health care impacting health outcomes. And the purple area is the overlap between psychology and biology. And in this overlap, we have the notion of cognitive development, which I'm going to spend a good deal of time talking about right now. So I know that we probably have parents here of children under the age of 13. I'm going to do most of my discussion of those 13 and over. You'll get to that age soon enough. It will happen quickly. So I put this slide in under construction because I believe that it's important to note that the adolescent brain is not a miniature version of the adult brain, nor is it a broken brain. This is a situation where with our adolescents, and one of my colleagues said this today, said I could quote her. We've all heard the saying, if it looks like a duck, it quacks like a duck, then it must be a duck. Well, this does not hold true for our adolescents. They may look like an adult. They at times may act like an adult, but they're not an adult. They're still growing. And I want to summarize this by this quote from an article of 2013 regarding adolescent brain development. The brain development of an adolescent is a fundamental reorganization of the brain that takes place in adolescence. In postnatal brain development, that being right after birth, the maximum density of gray matter is reached first in the primary sensory motor cortex, and the prefrontal cortex matures last. Subcortical brain areas, especially the limbic system and the reward system, develop earlier, so there's an imbalance during adolescence between the more mature subcortical areas and the less mature prefrontal areas. This may account for typical adolescent behavior patterns, including risk-taking. So what this is telling us is that our brains develop backwards to front. And the sensory motor part in the back part of our brain takes predominance first. And over time, we develop more gray matter in the frontal part of the brain. This progression graph shows with the purplish or violet or whatever color you want to call that, you can see the percent of gray matter volume over the course of the lifespan. Now, this is important because gray matter are the areas where the actual cognitive processing is done, whereas the white matter provides the communication between different gray matter areas and between the gray matter and the rest of the body. And the neurons in the gray matter consist of neuronal cell bodies and their dendrites, and that's where the communication's taking place. So before we get to that, I think my notes are a little, while there is growth in the gray matter, there are additional processes that do occur. And we are going to watch a short clip in a little bit that takes a look at that. But first of all, there's another feature of development that impacts the period of adolescence in a major way, and that is sexual development and the dumping of hormones into the neurochemistry, shall we say. And that is taking a look at what the tenor stages of development, you can see for girls, stage 4 and 5, what happens, and then with boys around the same ages, what begins to happen. What's important about this is that these hormones do impact our brain development and interact with what's happening in the brain. Some people call it raging hormones. I don't think that overall is true, but it does impact the behavior of our adolescents. So for this part, I want us to watch a video by Dan Siegel regarding the adolescent brain and what happens.
David, just a quick interjection. You may need to reshare your screen in order for the audio to come across here.
Okay. Okay, I was told I need to reshare my screen.
Yeah.
Okay, with a new share?
Yes, yep. So when you go to share screen, if you click the up arrow and then share with system audio.
Share sound.
There we go.
Thank you. All right, let's try this again because this is worth listening to.
The adolescent period is absolutely amazing.
Is that good?
People often give it a negative approach.
Perfect,
saying,
thank you.
Oh, it's a time where adolescents are going to lose their mind, or they're just immature, or raging hormones drive them crazy. These are all not only wrong, but they're myths that mislead us and actually disempower us. Whether we're adults or adolescents, they actually give us the wrong message and they make it so there's nothing we can do. So what is actually the truth? The truth is that instead of raging hormones, what's happening is we have remodeling in the brain. In ways we never could have predicted, we now understand two big things are happening in the brain. Things you as an adult can support adolescents in developing well, and if you're an adolescent, you actually can use this to help your brain grow in an optimal way. What are those two things? The brain is pruning itself. So imagine that in childhood, you're growing like a tree and establishing all these branches and all these leaves are growing. In the brain, that means connections among the basic cell, the neuron, called synapses, are being established, and you're soaking in the knowledge of the world, and that's beautiful. The tree is just growing, growing, growing. But then what happens that surprised everyone is the brain begins to prune itself. You start carving away some of those leaves, some of the smaller branches, even some of the larger branches. And the reason for the pruning is to specialize the brain. While the child is developing in ways that are really generalized, learning everything they can about everything they can, an adolescent is going to begin to find their passion, to actually find things they like, things they really love doing, and to drive their development in that way. So pruning is actually a use it or lose it principle underneath it. That if you don't use something, you're gonna lose it. So if you like sports or like dancing or like music, do those things so you continue to establish those circuits. The second thing that happens in the remodeling adolescent brain is myelin formation. Myelin is a healthy sheath that allows connected neurons to communicate with each other in a much more effective way. How? It's 100 times faster, the signal that's sent down a neuron to communicate with another neuron, 100 times faster, and after it fires off, it's 30 times shorter the resting period that happens. 30 times 100 is 3,000. So when you've put down myelin, you've made your neurons communicate 3,000 times more effectively. That's a great thing. Now, the great thing too is that you as an adolescent can actually use the focus of your attention to be aware of your emotions, aware of other people, to be engaging in activities, to be doing things with your thoughts that actually reinforce the parts of your brain you want to hold on to. So the good news about the remodeling story is that a field called neuroplasticity, how the brain responds to experience, shows us that what you do with your mind can change the activity and therefore the structure of your brain. So if you then come up with the statement that the ultimate goal of brain remodeling is to make an integrated brain, to differentiate areas, that's the pruning, and myelinate them, that's the linkage. When you increase differentiation and linkage, you make the brain more integrated. And an integrated brain is the pathway toward well-being. And you can do mind-sight exercises. These are exercises that increase insight, empathy, and integration. And if you do them as an adolescent, and you can also do them as an adult, you'll actually increase the integration of your brain as your brain is growing, not just during adolescence, but throughout the lifespan. And what's the outcome of integration? When integration is made visible, it's kindness and compassion. And so what we see through adolescent development is that our relationships become built on connections that are deep and filled with honoring each other's vulnerability, that's kindness, and supporting connections that are compassionate, filled with a sense of caring about other people and wanting to help them. This is the kind of world we can build as we move through life and support each other in our development.
I would encourage anyone interested to go to Dan Siegel's website to take a look at some of the exercises. And I think it's important to highlight here, especially since that I'm the guest of Hill Center tonight, that one of the things that Hill Center does is work on that neuroplasticity. It is teaching new ways, different ways to learn, and with repeated application, there is tremendous improvement. So just a shameless plug for the Hill Center. Okay. All right. Chris, why am I not getting?
If you move your mouse to the bottom left, you'll notice a right and left arrow, and you should be able to, yep, there you go.
All right. It's getting ahead of itself. Sorry, folks. This is not familiar technology to me.
If you, there you go. If you move your arrows, you can also move back and forth.
My arrows have stopped working. Oh, there. Okay. All right. Sorry about that. Okay, moving ahead. All right, the psychological tasks of development here. I want to focus on 3 areas of study and thought. I want to look at cognitive development, moral development, and personality development. And for that, I want to draw our attention to the area of cognitive development. Speaking off the work of Jean Piaget, for those of you who've had an introductory psychology class, you will have heard this name before. And according to Piaget, who was a Swiss psychologist, adolescence from ages 12 and up is a time during the development of something called formal operations. And the major characteristics of this time, the adolescent or young adult begins to think abstractly and reason about hypothetical problems. Abstract thought emerges. This is why we think they are more like adults than they really are. Teens begin to think more about moral, philosophical, ethical, social, and political issues that require theoretical and abstract reasoning. And they begin to use deductive logic, or reasoning from a general principle to a specific information. Closely associated with the work of Piaget was the work of Kohlberg, who talked of the moral development over a person's lifespan. And during adolescence, the time of moral development is a time of conventional level of moral reasoning. To reason in this way is to judge the morality of actions by comparing them to society's views and expectations It's characterized by an acceptance of society's conventions concerning what is right and wrong, and the person obeys rules and follows society's norms even when there are no consequences for obedience or disobedience. I think for adolescents, it's not only society's expectations, but it also becomes what are their tribe's expectations. And that becomes probably much more foundational to their moral development at that time. And then during this period of time in adolescence is what happens to our personality. And for this, I go back to the work of Erik Erikson, psychosocial theory of personal development. And what Erikson, a psychologist of 1950s, suggested in his theory that there are a series of life tasks that we accomplish corresponding to certain developmental stages. I think we all, when we are parents of young children, particularly infants, we know that the first task is basic trust versus mistrust. And we proceed through until we get to the adolescent period of ego identity versus diffusion or confusion. And during this age of adolescence, we establish our identities along various dimensions. Those dimensions may include what our values are. They may include what we're interested in studying. They may include what we are interested in doing with regard to our free time. Okay, so with all these bodily changes that occur during adolescence and cognitive changes, there are many opportunities for never before seen behaviors in our teens to surface. And so I'd like to spend a little time talking about what typically can develop, though still be considered challenging. Before we do that, I have a pop quiz. Is this typical or ADHD? I have no answer for that. I would guess maybe a little bit of both, but many of your children's bedrooms may look like this. Okay, typical, but still challenging. The first on the list, many of you with teenagers at home may understand that there can be some verbal aggression that happens. And this is considered typical adolescent behavior, especially in boys. Hormonal changes combined with the desire for more independence can cause teens to lash out with hurtful words, yelling, or arguments. While verbal aggression is considered typical, when it becomes abusive or turns into physical aggression, then it's time to get help. I think sometimes what we see with some of our teens developing, typically, they may be verbally aggressive, and then 30 minutes later, after they've had time to think about it, they'll come back and say, "I'm sorry, Mom, I didn't mean to say that." If there's verbal aggression and you see no remorse, then you might want to be looking into why. Lower frustration tolerance is another thing that's fairly typical within the adolescent age. Hormonal changes and confusion about their place in the world can also cause a lack of frustration tolerance in our adolescents. Other environmental forces might include bullying, low socioeconomic status, peer pressure, lack of support from home, difficulty making friends. Adolescents become easily frustrated, and that frustration can lead to emotional or aggressive outbursts. Studies have shown that testosterone levels do increase this type of behavior in teenage boys. Low impulse control. It is normal for teens to have a lower level of control over their impulses. And I hope I've laid the foundation for why that may be so. Children in general tend to act on what they want, often without thinking through the consequences. Teens are no different, except what they want could have far more dire consequences than when a child wants ice cream for breakfast. Low impulse control can lead to typical adolescent behavior, such as blowing off schoolwork to go to a party or school event, experimenting with alcohol at home or at a party, or lying when they feel exposed. It's when there becomes a constant or continuous pattern of this behavior that we become concerned. Withdrawal from the family. It is typical adolescent behavior for your adolescent to withdraw from family and spend more time with friends and peers. Increased social interaction with peers should be encouraged during adolescence. Now, I will say during this time of pandemic that this is one of the biggest areas of controversy, especially when a family is trying to be safe. Adolescents may evaluate the risk differently and they want to be with their friends. And so I have had occasion to counsel families where the child has gone out against their parents' wishes to be with people who are unmasked. So I would say that if you can increase that social interaction in the safest way possible. If your teen's withdrawing from all social interaction, that being family and friends or peers, then it's time to be concerned. So I'd say pay close attention to your adolescent, make sure they're getting adequate social interaction. If they're withdrawing and isolating themselves, it's time to be concerned. Sleeping, harder and longer is pretty typical adolescent behavior. Teens grow pretty quickly between the ages of 14 and 17, and it's pretty typical to sleep harder and longer during these intense growth spurts. Your teen may be reluctant to get out of bed in the morning. Your teen may be reluctant to go to bed early or sleep for as long as 12 hours per night on the weekend. If your teen sleeps harder and longer for a long period of time without any kind of let up, that may be a sign of something going on with mood. So I think if you have that behavior in association with some of the other things that we're talking about that happen over a longer period of time, it would be time to be more concerned. There can be an increase in appetite because there's so much physical growth during these years. You will notice that you will buy a gallon of milk and it will be gone within a day. You will go to pour yourself a glass of milk and there's no milk left. Or most likely, there will be an empty milk container in the refrigerator that you had no part of. So there's going to be more eating and at meals and in between meals. Teens may not make the healthiest food choices, and that's where your guidance is going to come in. If your teen constantly is eating and starts gaining weight quickly, then you need to see a doctor to make sure there are no health concerns that need to be addressed. Now, speaking of, and it's not on here, there can be not an appetite increase, but you might see your teen trying to restrict their food intake because of some societal norm that they want to fit. And that is a concerning behavior, particularly if it is accompanied by significant weight loss, or that you hear of episodes of purging. There can be light risk taking that is that takes place in adolescence. It's related to low impulse control and peer pressure, two things that we've already established in this age group. It's normal for kids to want to fit in with a crowd, and teens are not always thinking through the consequences before making a decision. This can lead to some light risk-taking behavior, such as experimenting with alcohol, skipping an occasional class. When these behaviors become dangerous to your teen or others, you may need help to address the problem. Concerns about physical appearance began to surface around this time because they, at the core, want to fit in with the crowd. Your teen may become pickier about clothing. They may worry about wearing off-brand shoes or spend hours in the bathroom prepping for a night out. If your teen starts dropping weight or changes their eating habits drastically, stops eating altogether, it's recommended to seek professional help. Defiance and testing limits. As teens fight for their independence, they're likely to become more defiant and test the limits of rules and expectations. It is typical adolescent behavior for your teen to ignore or argue with you about the rules. It is typical for you to hear, "My friend's parents don't have the same rules." Truth be told, they do. Or at times to outright refuse to do things that are asked. While this is frustrating for a parent, it is a typical part of growing up that every teenager goes through. Lowered self-esteem. Many adolescents do have low self-esteem, particularly during the awkward stages when they feel as though they don't belong. This can come about as changes in their body makes them feel ganglier or more awkward. When they don't feel like a child anymore, but also don't feel like an adult, they may wonder about their place in the world. This can lead to low self-esteem or poor self-image. If your teen becomes despondent, depressed, or withdrawn, then again, it's a time for you to seek help. Abandoning commitments is a typical teen behavior that is really hard for many parents to accept. Many in this age group will abandon previous commitments as they discover what is important to them. If your teen played an instrument or a team sport and suddenly loses interest in the sport or drops out of band or whatever musical group they have been part of, don't be surprised. This is typical adolescent behavior that should not be a cause for concern. If, however, your teen has little interest in anything at all for a prolonged period of time, it could be a sign of depression. Selfishness. You may notice that your adolescent is selfish. Many adolescents think only of themselves and they rarely consider the thoughts, feelings, or actions of others. I've had one adolescent tell me, "It's like I'm in my own movie." That I am the main actor in my movie. This is because your teen is trying to figure out who they are as people and trying to find their place in the world. This leaves little attention for people or events outside their immediate spheres of interest and understanding. Curfew violations. Now, this would be pre-pandemic, because many kids have not gone out and needed curfews, but that can be a typical adolescent behavior. While it's frustrating and seemingly dangerous at times, it is typical for an adolescent to miss curfew. Teens often don't have a great sense of time, and this is related to their cognitive development. They may lose track of time easily, especially when spending time with their peers at social engagements. And sometimes they will miss curfews for good reason. I've had some teens say that I drove a friend of mine home who was drinking too much, and I wasn't. So they were a designated driver. So you might want to go easy on them for those types of curfew violations. Privacy interest is, struggle with sense of identity. This is fairly typical. Our teens go through phases such as if they are bookworms and then abhor books. They may dress differently or gain interest in completely different things than they enjoyed in the past. And one thing that we do see more common these days than when I first started practice, it's more common for teens to grapple with gender or sexual identity. This is typical, and after a period of extreme angst, they may come out on the other side the same person that they were, but they may be headed in a different direction. Mood swings. Let's see, I think I might, no, I'm not behind. These are some things I don't have on here, but listen up. Mood swings are a typical behavior as your child grows into adolescence. The massive hormonal changes that teens are going through affects the production of dopamine and serotonin in the brain, causing frequent mood changes. A teen may be completely peaceful one moment and crying the next. Mood swings can be a cause of concern, however, when they are drastic, frequent, and extreme. Many mood disorders are first discovered during adolescence. There is a greater sense of interest in privacy. As a teen grows up, it's important that you allow them this privacy. Part of this interest in privacy will be due to changes in how they think about their sexuality. Your teen will also have a greater interest in keeping thoughts and feelings private. Teens may keep a journal or diary or they have trusted friends with whom they can talk. Sexual experimentation, an area that is often very concerning to parents, is extremely normal for, I use the word normal, typical for your teen to want to experiment with sex. Their experimentation may have to do with exploration of their own body. On the other hand, as they get older, they may become curious about sex with others. If your teen is not only sexually active, but sexually promiscuous, then it's time to consult with a professional. And frequent changes in relationships. It's fairly typical for your teen to change relationships frequently. You may have a difficult time keeping up with whom they're dating or when those relationships start or stop. If your teen is showing any of the more concerning signs of adolescence when it comes to relationships, for example, promiscuity, it's a good idea to be in contact with a therapist. So all of these things can be typical for adolescents. And the next one is also typical, but we begin to move into the realm of what becomes more clinical. And that is the area of anxiety. And I must say, in the 35 years of practice that I've been engaged in, this is one area that has increased in occurrence the most, I would say, within the past decade, and particularly during the pandemic, it's gotten even worse. According to the National Institutes of Health, nearly 1 in 3 of all adolescents ages 13 to 18 will experience an anxiety disorder. And these numbers have been rising steadily since the early 2000s. In addition, there has been some preliminary research taking a look at the rise of anxiety during the pandemic, and as we would all guess, there is a rise. It is a marginal rise compared to what has been going on, but there still is a rise. So why is this happening? We don't know for sure, but the following are suspect. Number one, high expectations and the pressure to succeed. I may be stepping on some toes here, but it is mind-boggling to me for some schools, high schools, to be pushing advanced placement courses in the freshman year of high school. Again, I don't mean to step on toes, but I think that we are dealing with the brains of 14-year-olds as freshmen, and we're beginning to set the bar that may become hard to reach. We live in a world that is scary and threatening, particularly during the age of the pandemic. And social media connectedness, which I believe personally is at the heart of the increase in anxiety. What we see in this list are two great fears. The first being fear of failure, FOF. Particularly if a child has a learning or attentional challenge, then they have a strong fear that they're not going to meet expectations. Similarly, with social media connectedness, fear of missing out, FOMO. People present lives as they may not be living on social media, and your adolescent may be sitting back looking at that presentation thinking, oh my gosh, I am not doing that. I can't be like that. What's wrong with me? So I think that anxiety has increased significantly, both from research and in clinical practice, and I think it may be related to these three factors. Mood. Now, I want to distinguish between mood and depression, or moodiness and depression. Moodiness is fleeting and usually can be triggered by an event. Depression is different. What we know from the literature is that major depressive episodes in adolescence tend to look more like adult depression with regard to cognition, the things they're telling themselves, and vegetative symptoms. And by that, I mean eating and sleeping. This finding is very different from the concept of moodiness. In a yet to be published article that I was able to get through a pediatrician friend at the American Academy of Pediatrics, there has been a slight increase in reported rates of depression and suicidal ideation during the pandemic. But prior to the pandemic, what we know is from 2005 to 2014, there was an increase of major depressive episodes in adolescents from 8.7% to 11.3%. And it is steadily climbing since then. All right, so let's think about this, because I, as a clinician, am very concerned about the potential for depression in adolescents. Again, moods can be fleeting and often are precipitated by change in circumstance. So considerations for distinguishing what is a passing mood and what represents depression fall along three continuums: the severity of the mood, how deeply depressed they are, the duration, of that mood? How long is that happening? Is it momentary, or is it happening over weeks, months, up to a year? And the domains, is it impacting their function socially, academically, and in family life? Okay, so when to worry? Even with these typical behaviors, I think it's important to worry when your adolescent experiences a decrease in enjoyment and time spent with family and friends. I believe it's time to worry when there are big changes in energy levels, eating or sleeping patterns. I believe it's time to worry when there are feelings of hopelessness, sadness, anxiety, crying often. I believe it's time to worry when there are multiple physical symptoms, when there's no medical cause. Stomach aches, headaches, and I've had more adolescents complaining of chest pain, particularly during this pandemic, than I have in any point in my career, which I attribute to anxiety and improper breathing, and being keyed up. When to worry? Significant decrease in school performance, or a strong resistance to attending school or absenteeism. During the pandemic, what we saw was people turning off their screen, not to be seen by their teacher. We worry when we begin to see problems with memory, attention, or concentration. And for sure, we begin to worry when we see substance abuse, dangerous or thrill-seeking behavior, or frequent aggression. We also begin to worry when we see an excessive neglect of personal appearance or hygiene. And the last two are very troubling. If the adolescent is overly suspicious of others, or if they report they're seeing or hearing things that others do not. Now, that last one doesn't necessarily mean that there's schizophrenia on the way. Many times people with OCD will report that they hear voices telling them to do certain things. But it is a different experience than people who may be prodromally schizophrenic. And I don't know how easily you're going to be able to read this slide. It didn't come out the way that I wanted it to, but this is a fact sheet from the National Institute of Mental Health. And it has a depression checklist. Do you often feel sad, anxious, worthless, or empty? Have you lost interest in activities you used to enjoy? Do you get easily frustrated, irritable, or angry? Do you find yourself withdrawing from friends and family? Are your grades dropping? Have your eating or sleeping habits changed? Have you experienced any fatigue or memory loss? And have you thought about suicide or harming yourself? All of these are going to be significant red flags for pursuing an assessment of depression. Okay, so I've given you a little bit of a framework of what's happening during adolescence. And now it's time to pivot to what is ADHD. And this is certainly been an area of interest of mine for a long, long time. And I've got to say that I was first introduced to this notion in graduate school, where I worked with a professor on a national grant that took a look at sugar consumption and hyperactive behaviors in preschool. In fact, I extended my graduate school career by a year to be part of this study. And what this study involved was keeping a 10-day food diary of everything that a preschooler ate. We had 500 of them. They came in at the end of the 10 days and did a series of lab measures, and parents filled out behavior rating scales. And we just thought for sure that we had discovered the new genesis of ADHD. It was sugar consumption. Well, guess what? There was no relationship. So that was the start of my interest in ADHD. And since that time, it's been a characteristic of folks that I've become quite attached to. So let's turn our attention to attention deficit hyperactivity disorder. And let me look at our time. Okay. So Russell Barkley is one of the big names in the field of attention deficit hyperactivity disorder. I will refer you to his website. There are phenomenal resources there for parents and teachers. And this is his definition. Attention deficit hyperactivity disorder, or ADHD, is the current term for a specific developmental disorder. You'll see I have that highlighted in red, seen in both children and adults, that is comprised of deficits in behavioral inhibition, sustained attention and resistance to distraction, and the regulation of one's activity level to the demands of a situation, i.e. hyperactivity or restlessness. This disorder has had numerous different labels over the past century, including hyperactive child syndrome, hyperkinetic reaction of childhood, minimal brain dysfunction, and attention deficit disorder with or without hyperactivity. Now, I've highlighted the specific developmental disorder phrase for a reason. And that is that what we are looking for when we make this diagnosis are developmentally delayed areas in attention, behavioral inhibition, and regulation of one's activity level. It also implies a specific developmental disorder. It also implies that this spans beyond preschool, school age, adolescence, into young adulthood and to later. So it is fairly chronic. Pop quiz question number 2. Is there an attention deficit in ADHD? Answer. Some researchers suggest there is no deficit of attention in ADHD. Rather, the problem rests with the regulation of attention and what we choose to focus on. So think about the amount of time your adolescent can focus on video games. It can be for hours. It's a different thing than tackling something that is of little interest. And I've got to say, this was provided by someone in this audience tonight. Some teachers think that ADD is the absence of discipline and direction. The truth is, poor teaching or poor parenting do not cause ADHD. However, good teaching and good parenting can make the effects of ADHD significantly better. Okay, let's look at the primary features of ADHD and break it down. So there's an impaired response inhibition, impulse control, or the capacity to delay gratification. This may look like having trouble standing in line. This may look like grabbing during testing, a child grabbing the materials, trying to get to responding to answers before I can even ask the question. There can be excessive task irrelevant activity or activity that is poorly regulated to situation demands. So this is the hyperactivity that we're talking about, or restlessness. Now in adolescence, that may not look overtly hyperactive, but you talk to them and they will say they feel like they're being driven by a motor. That's one of the reasons why back in the day, people used to think everybody grew out of ADHD, because the behavioral aspect of it seemed to get better over time. And that is true. What happens is it becomes more internal, particularly in adolescence. And then the third primary feature is poor sustained attention or persistence of effort to task. And this would be poor sustained attention for activities that one finds not very reinforcing. Now, what we're finding in more recent research is these associated features that can be quite problematic. And those are struggles with working memory, that being the ability to hold information in short-term memory and do an operation with it, and processing speed, how quickly you can go from what's in your head on paper. We also find difficulty with regulation of emotions, difficulty with regulation of motivation and arousal level, and greater than normal variability in task or work performance or completion. There is a saying that a student with ADHD does well on an assignment on one day, and we hold it against them the rest of their lives. How often have we heard, well, they did it on Monday, why aren't they doing it today? The one thing that is consistent about their performance is the inconsistency. And granted, it is hard to understand, but it is certainly a feature and is a great source of frustration for students. One young man that I work with who is in college struggles with the executive functioning aspect of school. And he's at a university far away, so we are Zoom meeting, and he was having trouble completing his college homework. And so I was trying to engage him in problem solving around what he could do. And he told me, if you're going to tell me just do it, I'm going to turn off my computer. The issue is they struggle with just doing it. Okay. So there are different ADHD subtypes. Many of us are still operating from the 1980s Diagnostic and Statistical Manual of the American Psychiatric Association, where there was attention deficit disorder with hyperactivity, impulsivity, and without. With the latest DSM, the overarching term is attention deficit hyperactivity disorder with different qualifiers. So if I tell you your child has ADHD and you become offended that I've used the word hyperactive in it, please don't. Listen for the qualifier. It is attention deficit hyperactivity disorder, comma, hyperactive impulsive type, predominantly inattentive type, or combined type. They are three different subtypes of attention deficit hyperactivity disorder. Now, over the years, or the past decade or so, there has been a new diagnosis, well, it's not formally a diagnosis yet, but as ADHD has gone through more studies, there's a new disorder that has arisen, and that's called SCT, or sluggish cognitive tempo, or concentration disorder. Some people think that this might be a subtype of predominantly inattentive type, but there are those who feel that it is totally different. It is distinct from ADHD, but shares some of the features. The person can present as daydreaming or spacey. They can present as being confused easily and misunderstanding directions. They can seem sleepy. They can seem very slow to finish, or they are slow to finish tasks. And for some, there's a resistance to physical activity. There will be more to come in this area as there is a refinement of subtypes. But it has certainly been the case in my practice that I have seen people who demonstrate these characteristics. We do the behavior rating scales. There's no hyperactivity, impulsivity, and actually they don't look that inattentive. But when you're sitting in front of them doing their work, this pace at which they do it, even though they have normal to high average to superior intelligence, is extremely slow, and they get the directions confused quickly. Okay, so how do we make the diagnosis? Spoiler alert, there's no one test for making the diagnosis. There is no blood test, no genetic test, no computer test. Although I will say there is testing that is done in all three of those areas. But the ability to be predictive of the establishment of the disorder and the course of it is suspect. What we do know is there is a strong genetic component. And this is one of the apple doesn't fall far from the tree scenarios. When I'm doing a history, I will often ask, okay, if it's your biological child, who is the child more like, the mother or the father? And I will often hear one of the parents say, I was just like that. I see where he gets it. It is strongly heritable. So there are some genetic markers that have begun to be established, but there's no gene test for it right now. We do have tests that we do as part of a full neuropsychological battery, which you will hear about in the next community education series, and I hope you join in. I'm not doing it, but two of my colleagues are, and they're great. They can talk you through what to look for in psychological testing. But there is no one test for making the diagnosis. So how do we make the diagnosis, particularly with adolescents, because there are several problems associated with making the diagnosis with adolescents. Number one, to qualify according to the DSM-5, symptoms must be present in some form before the age of 12 years. So if we are waiting until adolescence to make this diagnosis, then what we're finding is time erases memory. If the child was not very hyperactive, it will be the case that sometimes it's hard to establish it before the age of 12. And then you go back to report cards. What comments did teachers make? And that can be very instructive. Many of the symptoms in the DSM primarily are written for the behavior of younger children, so that's a problem. I'm going to read through some of those for you in a minute. Obtaining reliable reports of symptoms from external observers is complicated. Now, one of the things that I think is extremely important are behavior rating scales. And there are several good ones out there. And I like ones where we can get ratings not only from the student themselves, but from the parents and from teachers. When you think about teachers, particularly at the high school level, not many of them know the student that well, unless they've had the student for a couple of years, unless they know the student from some extracurricular activity. So even though we try to get the information from high school teachers, what we find is it looks pretty flat. So we can't always rely on teacher report at the high school level. Another problem is that some of the striking features of the diagnosis may be more subtle in teens. Again, hearkening back to the notion of that hyperkinesis or overactivity, we may not be seeing it as much outwardly, but they are reporting it inwardly. And the presence of other disorders complicate making the diagnosis. And for this, I want to talk about anxiety and depression. So it may not be surprising to you guys that for adolescents with attention deficit hyperactivity disorder, there is a strong co-occurring or co-occurrence of anxiety and depression, and the combination of anxiety and depression. There are some estimates of anywhere from 35 to 50% of adolescents diagnosed with ADHD have a co-occurring anxiety disorder or a co-occurring depression or the combination. So we will often see, and I'll talk about this a little bit later, people presenting for therapy with anxiety or people presenting with depression. It's always a red flag for me to start digging around into their attention. And once I do, I start finding a gold mine. It is not necessarily chicken and egg, but it is the case of they co-occur and make each other worse. So what are the essential components of the assessment? What's the history of the behavior? We need that, particularly for establishing the before 12 diagnosis. We're looking for the impact on current functioning. What are the functional limitations? We're looking at birth history and early development. Interestingly, and I will often ask, well, I routinely ask about this in an intake. Does your child or teen have a history of chronic ear infections? There is for a good number of folks with ADHD, there was a history of chronic ear infections. We don't know why, but it's there. What kind of history of accidents has your teen had? How many broken bones? How many trips to the ER? How many trips to the pediatrician with unspecific complaints of pain? What's the school history and teacher comments? Again, the teacher comments are very important in the former teacher comments are very important for taking a look at the diagnosis. I also like to look at in terms of school history, what happened when the student went from elementary school to middle school. So think about what happens. Typically, you go from one teacher or maybe two team teachers to having anywhere from 6 to 8 teachers, with 6 to 8 expectations for when assignments are due, and being able to keep up with those demands. If I begin to see some faltering in middle school that from which there's not a recovery, I am strongly suspecting some attention difficulties. I'm also looking at family history and looking at social history. Family history, I am looking for history of alcohol use, substance use, because they are great masks for depression and anxiety. And anxiety and depression are great masks for attention problems. Okay. And what is the social history? What kind of difficulties has the child had making friends, keeping friends? All of these are important in the process. Behavior rating scales, I think, are important to be able to rate compared to other students their age. Again, going back to Barkley's definition of a specific developmental disorder, are we looking at how this person is presenting currently? Does it appear to be behind same age peers? Neuropsychological and psychoeducational testing, Russell Barkley will argue, is not necessary. And I tend to agree from the standpoint of making the diagnosis. I disagree from the standpoint of determining, are there co-occurring learning problems? And what kind of educational programming needs to be in place for the student to function at his or her best? Not only is there a significant overlap of anxiety and depression with ADHD, there is a significant overlap of learning disorders and executive functioning disorders with ADHD. And the only way we can get to that is through neuropsychological and psychoeducational testing. My apologies to Russell Barkley. I still respect him a great deal. I just wanted to read to you, and I didn't want to put this in the printout, but I wanted to tell you the kinds of things that we're looking for in making the diagnosis based on the DSM-5 criterion. So we're looking at the domains of inattention and hyperactivity, impulsivity. So within the inattention domain, 6 or more of these symptoms have to persist for at least 6 months to a degree that is inconsistent with developmental level and have a negative impact on social, academic, occupational activities. Often fails to give close attention to details or makes careless mistakes in schoolwork, work, or during other activities. Often has difficulty sustaining attention in task or play activities. For example, difficulty remaining focused during a lecture, conversations, or lengthy reading. Often doesn't seem to listen when spoken to directly. Mind seems elsewhere, even in the absence of any obvious distraction. Often doesn't follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. May start quickly, but then lose focus and gets easily sidetracked. Often has difficulty organizing tasks and activities. Difficulty managing sequential tasks, keeping materials, belongings in order. Messy, disorganized work, has poor time management or fails to meet deadlines. Often avoids dislikes or is reluctant to engage in tasks that require sustained mental effort, schoolwork or homework. For older adolescents and adults, it may be preparing reports, completing forms, reviewing lengthy papers, or in my instance, doing my taxes. Often loses things necessary for tasks or activities, school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, mobile phones. Is often distracted by extraneous stimuli. For older adolescents, this may include unrelated thoughts and is often forgetful in daily activities, doing chores, running errands. For older adolescents and adults, returning to class, paying bills, keeping appointments. So to score on the inattention dimension, you've got to have 6 out of those. For the hyperactivity and impulsivity, you have to have 6 or more of these. Except they do give the exception of for someone 17 and older, 5 have to be impaired. So for hyperactivity, often fidgets with hands or feet or squirms in seat, often leave seat situations where remaining seated is expected, often runs about or climbs excessively in situations in which it is inappropriate. Now, if an adolescent is doing that, that would be seem odd to us, but in adolescence, it may be limited to subjective feelings of restlessness. Often unable to play or engage in leisure activities quietly, is often on the go, acting as if driven by a motor, and often talks excessively. And that's hyperactivity. And with impulsivity, often blurts out answers before questions have been completed, often has difficulty awaiting turn, often interrupts or intrudes on others. So to be diagnosed with the combined type, you need 6 out of the first category and 6 out of the second category. To be diagnosed with hyperactive impulsive, you have to meet 6 of those. If you're diagnosed with predominantly inattentive, 6 of the inattention. And you have to show that there are impairments from the symptoms in 2 or more settings. That might be home, school, work, or friends and relatives. And then there's clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. Now, there have been some proposals to take a look at this list and change it, particularly for adolescents. And those would be often easily distracted by extraneous stimuli, often makes decisions impulsively, often has difficulty stopping activities or behavior when they should do so. Think video games. Often starts a project or task without reading or listening to directions carefully. Often shows poor follow through on promises or commitments they make to others. Often has trouble doing things in their proper order or sequence. Often more likely to drive a motor vehicle much faster than others. Excessive speeding. If the person has no driving history, substitute. Often has difficulty engaging in leisure activities or doing fun things quietly. Often has difficulty sustaining attention in tasks or leisure activities, and often has difficulty organizing tasks and activities. So 6 of those 9 symptoms. That's not become a norm yet, but there are folks that are looking, particularly as more adolescents and young adults are presenting themselves for assessment of things to look at. Now, David,
let me interrupt you real quick. I want to note the time, and I just want to note for participants that this information is so valuable, and the comments in the chat, people are really enjoying your presentation. They're asking great questions, and I want to be sure we leave time for that.
Okay.
So if participants don't mind hanging out just a little past 8, we'll do the Q&A, and we'll be getting to that very soon.
Okay. Sorry, I got lost in. I can go on and on about this stuff.
That's not a
I,
problem.
I think it's also important to note there are other problems that are associated with ADHD that go beyond the classroom for sure. And sadly, that goes to the road. Students with ADHD tend to have more ER visits related to automobile accidents, tend to have more moving vehicle violations, speeding, and those two things themselves put those students in extreme risk. There are other predispositions to addiction, to alcohol, to various drugs, and to more recently to the internet. And in the research that has been done since the rise of internet, there is a growing consensus that ADHD is a risk factor for internet addiction. And it does not seem to be, it seems to be unidirectional. Attention problems tend to make you more likely to be overly invested in video game playing and social media, the telephone. It does not seem to be, as of now, although I specifically think that there could be a relationship, that the overuse of those things don't help your attention, but I don't think it causes ADHD. The other thing, and we talked about teens and their sexuality and sexual behavior, there are more STDs, there are more unwanted pregnancies that occur with those who have been diagnosed with ADHD combined type and the hyperactive impulsive type. Okay, let me talk a little bit about what I've observed in my practice over the years. While not always true, the brighter the student, the longer they're able to get by until a diagnosis is made. I have tested a person who is one semester away from their electrical engineering degree, diagnosed with ADHD, clear and simple. Extremely bright, worked hard, slept very, very little to make up for the impact of it, but it can happen. I've also seen that girls tend to get diagnosed more in middle and high school. Boys tend to get diagnosed more in elementary school. Think the squeaky wheel gets the grease. Also see girls presenting with anxiety more often. This is always a head scratcher for a lot of folks. Students with attention problems often struggle with homework initiation. And even if they've initiated it, completing it, or even if they've spent 3 hours working on a project, not turning it in the next day. And it leaves people just shaking their heads. Why? From the testing, and maybe my colleagues will get into this a little bit later, reading comprehension is often problematic due to the demands of working memory in the process, even when word decoding is fine. I see kids who can decode up a storm, and you put a page in front of them and have them read it, and they look up and say, I don't know what I just read. And if you think about it, That involves working memory, holding information in short-term memory to be able to string it with the next thought and the next thought and the next thought to be able to have comprehension of what is read. And written language often is marked by minimal content related to impaired effort. They have great ideas and can dictate wonderful stories. But when you put the pen to paper, because of the sustained effort requirements, and for many of them, the problems with just fine motor control, it becomes problematic. Thankfully, we have computers. Seeing less of ADHD presenting as a standalone diagnosis. 20 years ago, that was more the case. It was a standalone diagnosis. We're now seeing that it's often accompanied with anxiety and mood difficulties, particularly during the time of COVID-19. Okay, let's go to the questions. It seems like we just got started.
I know, it does. It flew by. All right, I'm going to start from the bottom and work my way up. Is there a disparity in the incidence of ADHD based on race?
So no.
Short answer.
Short answer, but that's a qualified no. I think that it is, I think sometimes that racial attitudes can cause teachers to wonder more about and refer kids for testing. So there may be a disparity in the referral process, but I would say that over the years, I've seen that even out a little bit. Now, I would be curious to know what happens within the public school. But what we know from the literature is that it occurs at the same incidence across different ethnicities.
Yeah.
And that incidence being 6 to 9% overall in the United States.
Do you have a particular author or maybe even a book recommendation for discipline practices for a child with ADHD?
Yes, Russell Barkley's book, Taking Charge of ADHD.
Taking Charge of ADHD. All right, thank you. You mentioned earlier one of the participants in the webinar tonight had attended another webinar that characterized ADHD as a mental health disorder. And something you said tonight led that participant to think maybe you had a different opinion of that. Can you talk a little bit about that?
I think the terminology needs to be strictly defined. I tend to think of it more as a sort of a cognitive disorder or an executive functioning disorder. Now, whether or not that is mental health, it depends on what you want to categorize mental health problems as. I tend to think of mental health problems as more anxiety, depression, but as we have seen, there is a strong interaction between those two.
Yeah, absolutely.
And to be clear, I also see children and adolescents and adults with attention problems, but who are very healthy in terms of anxiety and depression.
Yeah, so it's not always.
They have people in their lives who help direct them and are their executive functioning agents.
What's your opinion of the role of medication in treating ADHD in younger kids and then adolescents? Do you have a difference of opinion based on that age difference?
I was waiting for a medicine question to come up. Okay, so I'm not a pediatrician, so what I'm about to say is based solely on my practice. So I have seen overall children under 50 pounds don't seem to respond well to stimulants, but you get a little bit of weight on them and they respond better. I think it has a lot to do with what is the functional impairment of the diagnosis. I know I worked with one young man very early on in my career who at that time was 4 years old, was jumping out of his second story window into the bushes below, who would dart out in front of cars. And his pediatrician enlisted the help of a psychiatrist and said, we have got to do something to make sure this kid lives. He responded well to the medication and continued to use it for some time throughout his life. And actually, I've seen him recently and he's doing quite well. So I think it's a very personal decision as to whether or not you want to try medication. Parents often ask, are there alternatives that I would recommend? And to be honest, I think that meditation has a very promising role in helping the symptoms of ADHD. But meditation is effortful. And we are talking about a practice that is daily, that may be anywhere from 45 minutes to an hour a day. And we're not going to see many kids do that. I think it's important when we think about medicine to think about that it is a trial. There's no guarantee that it's going to work. It works in about 85% of ADHD combined type and not so great in 15%. We don't know until we try it. And even after you try it and see that it's helpful, then you may decide you still don't want to use it. So I don't know if that gets to the bottom of that question. It's whenever the child presents and adolescent presents and what is the functional impact of the ADHD and how do we make that better the quickest. What we do know from a multi-site study that Duke was involved in, this was about 15, 20 years ago, that that medication makes the biggest impact initially. And over time, the skills that the student learns through their teaching, through home, sort of went out. But it's more of the interaction of those two interventions that lead to the best outcome.
I want to take it. Actually, I'm gonna ask you a second question that I'm terribly sorry. I'm going to ask you a question that's related to that, and then I need to back up on one of the questions. The way I paraphrased it, I missed the gist of what that participant was asking, so I'm going to revisit another one. But before I do that, we were just talking about medication, and someone wondered if diet changes or vitamins help with ADHD. Is there anything that's recommended in that realm?
The research overall suggests that dietary supplement of fatty acids can be helpful. There are some vitamins that can be helpful. They certainly don't have the same impact that a stimulant does, but over time, there's a great chapter regarding nutrition in Barclay's book, which is in its 4th edition, Attention Deficit Hyperactivity Disorder, a handbook for diagnosis and treatment. And he just debunks the whole sugar hypothesis, but does talk about the promise of some of the omega fatty acids, and some vitamins.
I want to, let me go back and revisit, and I'm going to read it verbatim so I don't screw this up. Can you provide any insight on diagnosis from a race perspective? It seems to this participant that far fewer people of color are diagnosed.
I think it depends on, yeah, I wish I knew more about the participant asking and what their experience has been, because what I find is, and we're beginning to see more of this, but I'm seeing more people of color coming forward for evaluation. And receiving the diagnosis. I think the question is access to care, and what kind of insurance the person has, if they have insurance. I think all those factors do play a part, and so I think there is a greater understanding that it does happen across ethnicities. But I do think that those social factors that we talked about might limit or be a limiting factor in a person's presentation for the assessment.
Yeah. And a couple of folks were wondering if you could go back and revisit your point, talk a little bit more about ADHD becoming more internalized in adolescence, or internal in adolescence.
Sure. So what we tend to find is the behavioral excesses that often happen with younger children, they get a lot of sort of negative feedback regarding those things, like, keep your hands to yourself, or, stop tapping, or, the things that I think our body uses to try to regulate our central nervous system. And I think over time, both through our history, our learning history, and well, it's probably mostly learning history, we began to stop those behaviors, but feel internally the need to be moving. I often see adolescents that I'm testing whose leg will just be bouncing the whole time. Teachers may see in their classroom someone's leg bouncing all the time, and it's helping with their focus. So I think in that regard, that adolescents' learning history has taught them, I don't need to be doing these other things because it draws undue attention to myself, and they figure out how internally to try to regulate themselves, or they feel it, they just won't do it because they're going to get negative attention.
Yeah. Let me ask you this. One person wondered if a child can outgrow ADHD, and another person has asked, is a child with ADHD an adult with ADHD? And I'm thinking that may be getting at the same thing.
Repeat the second question.
Is a child with ADHD an adult with ADHD? In other words, if I'm that way as a child, will I retain that as an adult?
The research suggests that whether, I'm not sure it's an issue about growing. I think what happens is over the course of our lifetime, there are things that we can become passionate about and find careers in, and perform well. I am not going to recommend for a medical student with ADHD to go into something like radiology, where they're going to sit and look at, pictures all day.
Yeah.
ER doc, go for it. I want someone bright with quick decision-making skills in a situation like that. So I think, the more fortunate folks find something that they're passionate about, pursue it, and then have people around them that help with the executive function issues that often occur.
Yeah, absolutely. By the same token, I guess, does ADHD get worse or become compounded during teenage years?
I think it does become compounded, yes. And in some ways, it internally gets worse. I don't think externally we see it as much, but I think because of the changes that we talked about earlier, and the increased demands for information processing, I think we do see it get worse in that regard.
Yeah. And another,
because if you think,
yeah.
Oh, I'm sorry, I was just going to say, if you think about, early education is learning how to read, learning how to write, learning how to do math. And then as you move forward, it's more application of what you have learned. And that application requires much more executive functioning. And we often see that impaired.
Yeah, big switch between the two. Are gender identity issues more common in students with ADHD?
Actually, I think they are more common in students who may be on the autism spectrum. And that is an area we have not talked about tonight, because that needs its own workshop.
Yeah.
But I think what we see in clinical practice is more students on the spectrum worried about or wondering about their gender identity.
Okay. If you have a child who's, if a parent has a child who is exploring this a little, how can parents support a child who's thinking through or experimenting with gender identity? If the parent is coming from a perspective of, I think this is probably a phase that's not going to stick. In other words, not overreact, be supportive, but not solidify anything for them.
Well, that is it in a nutshell. Don't overreact and be supportive.
Yeah, do just that. Do just that. Yes. So that
Now,
parent answered
I
your
will.
question.
I will say something that I have seen is that people that I've worked with who are questioning gender identity want the quick fix. So there are three phases of transition. There's social transition, and then there's the medical transition, and then there's the legal transition. What I'm seeing, particularly with a lot of the adolescents that I see, they want to go straight to the medical. They want to start the hormone treatment immediately, and it's like, we're not doing that. There is a course to this. So socially, what are you doing to experiment with this gender role? Are you wearing clothes that you associate with the gender that you want to be? And it's only after they do that that I would even entertain the notion of the next step.
Yeah.
But they need to be trying it on, literally.
Yeah.
Yeah. And metaphorically.
Yeah. Yes. Talk a little bit about a relationship, if there is one, between screen time, video games, and ADHD. I think this person might have been looking for a causal relationship, but I don't.
I
wanna
think
assume.
that the potential for internet addiction or technology addiction is greater than in ADHD children, because if you think of, or in adolescents and adults, because if you think about, there are a couple of things that work, particularly with video games. You can take risks without being physically harmed. So it's great for risk takers. And number two, the stimuli is changing constantly, and you're getting significant download of dopamine, which always feels good. There's not much that is suggesting the other direction, that playing the games causes attention problems.
Yeah.
I think there might be some slight problem there, but I think it's more likely that someone with the diagnosis is going to become overly dependent on the technology.
Yeah, absolutely. But you talked a little bit about, and I noticed it got a big nod from our executive director, Beth Anderson, when you said it. You mentioned earlier that ADHD, and I'm going to misquote this, but ADHD, it's not the attention factor in the brain, it's the ability to regulate attention.
Right.
And so what I'm hearing you say is that attention regulation is simply more difficult, or is attention regulation impossible for these kids?
More difficult.
Okay.
A lot depends on what is the task at hand. How can that task be broken down so that you can manage, being able to have short bursts, being able to sort of plan out what that effort is going to look like. I think at the front end is really important in being able to evaluate it on the back end. How did I do? Where are the gaps? Yeah. It's not impossible. It is hard, but not impossible, and needs a lot of external support.
I don't, that really did pretty much cover the questions that came in regarding ADHD. And what I want to do, if you'll hang in there, David, and if our participants will, you highlighted the importance of depression and anxiety. You talked about that at length, even though this topic tonight was billed as ADHD, because they can be concomitant. But we got a few questions about that I think are worth hearing an answer from you. If you
Sure.
okay.
Yes, I would welcome that.
All right. One of these, I guess, does, you talked about some typical teenage behavior being, that a normal amount of frustration. One parent wondered, are intermittent episodes of, intense frustration or anger in which things get broken? Is there any version of that could be considered typical, or is that a sign that a child is struggling?
I think it's a sign that the child is struggling. It's an intermittent explosive disorder, which is a mood disorder. And I would say that is something that ought to be looked at.
Okay. All right. And how can, this was a separate question, but still dealing with that area of frustration. How can a parent help a child to de-escalate when their frustration or emotion is at a high level? Is there a way to sort of intervene and break that up or de-escalate?
That is a great question with not so easy answer.
Okay.
I think the important thing in that situation is not, as a parent, to match the intensity of the intense person at that time. So in other words, become Gandhi-like, or Buddha-like. Just, stay as calm as you can be. Lower your voice in response to the extra volume coming out of that person, and give them space. And I think particularly as our students get older, that you can do more problem solving after they've calmed down than you can in the midst of it. And I do think, and I would refer this person back to the work of Dan Siegel. He has some great resources on parenting, and particularly taking that mindset approach to parenting. But I think the main thing is to, as that person gets more expansive, the parent in the situation needs to try to become, at least on the outside, calmer, and drop their tone of voice and give some space. And if that person needs some time away, then you can go back and revisit and do the problem solving around the behavior. There's nothing that says it has to be immediate.
Right. The same idea of kind of interrupting this cycle. This one parent described a 10-year-old that's never liked school. They're very hard on themselves and down on their abilities. They rush through any assignment or give up if it requires effort. You know, how can you interrupt that or help to intervene with that with a student?
Wow, there's a lot there to unpack. Yeah. I'm trying to think of some sound bites for this parent. First off, let me just say I feel for you as a parent. That is a very difficult situation to be in, and you've got to feel helpless. And I'm sad about that for you. It's also sad for me for your child to think that he or she is not good at school. And I don't know if there has been an assessment, but I would wonder about the presence of some type of learning or attention or executive functioning problem. I think that's probably going to be at the core of my answer, is that needs to get assessed first. If that has been assessed, then I would be in communication with the school about what you're seeing at home and what can the school do to accommodate the student so that they are not feeling so overwhelmed when they get home, and so they can begin to have some successes to build on.
Yeah, absolutely.
But I think the first thing is a good evaluation.
Yeah.
And if the child's in public school, that the parent can ask for that.
Should a parent seek help if their child seems to be down and just a bit more apathetic in the winter time? In other words, the parent suggested we could be looking at seasonal affective disorder, and just wondering about that.
I do think that is a thing. And I think our kids experience that just like adults do. What the person may want to do is check in with their pediatrician about that. Whether or not, I mean, you can buy lights to help with that. You might get a prescription from the doctor for that so that your insurance might cover it. But I would think that would be an important thing, and also making sure that while the sun is shining, getting some physical activity is going to be an important part of that, getting aerobic activity.
This is an interesting, I'm hoping Liz is still on. We still have quite a few participants, and I kind of glanced back at the chat to see if there were any more questions about ADHD, and I'm noticing a couple. One I'm really interested in hearing your answer to too, because I've never heard of this, but does trauma predispose a child to ADHD? This person has noticed the trend of it seeming like a lot of kids in foster care have an ADHD diagnosis.
Yes, trauma does predispose children to ADHD. So there are two ways there are two pathways, I think, to that. I think trauma does do some damage to the brain that can be worked on, but can do some damage to the brain. And also, with children in foster care, again, you have to look at what was the genetic contribution of their biological parents. And I would think that we probably would be seeing a fair amount of ADHD in the biological parents of those children that contributed to them being in the care that they're currently in.
Yeah.
But yes, their trauma can be a pathway.
Are you familiar with Endeavor RX? And the RX is capitalized like the shorthand for prescription. So are you familiar with Endeavor RX, a video game recently approved by the FDA for treatment of ADHD symptoms? I have heard of it, and I have not worked with anyone who's used it yet. Okay.
But I wouldn't have a problem with thinking about it. Yeah.
Is there any comorbidity between ADHD and Tourette's syndrome?
Yes, there is. I can't give you the percentage, but yes, there is. A lot of times students who present with Tourette's disorder do have attention problems as well.
Okay, now this is a personal question now, because I'm gonna jump off of that. Based on my experience, I have noted students who didn't have motor tics prior to beginning stimulant medication. We noted them when they started medication. Is there a connection there?
So what I hear psychiatrists say is that there was an underlying predisposition to the tics to begin with, and the stimulant just uncovered it. I don't know about that.
Okay.
I think that's kind of an easy way out. I will say that it becomes a little bit more difficult medicating a student with Tourette's and ADHD because of the fact that stimulants can cause an uptick or increase in tics.
Yeah.
Yeah.
Yeah, absolutely. We had somebody on from Australia tonight, Dr. Riddle. I don't know if you know that or not, but we had somebody here from Australia. And we're wondering, yeah, exactly. Wondering about the Connors rating scale as an effective rating scale, if you were familiar with that or knew about that.
The Connors we use all the time. Yes. So I do recommend it. I do understand it's about to go through a revision and is not going to be available in paper form. It's going to be
all online
administration.
Okay.
But I bet they will relent on that because I think there's going to be an outcry. So.
Yeah.
But yes, Connors is one of our go-tos.
You mentioned certainly parents experience some of the externalizing behaviors of ADHD at home during homework. But can you talk a little bit about what you believe is the best school environment for a student with ADHD? In other words, what would be in place that might allow that child to prosper there? You know, besides Hill Learning Center, that's a given.
Okay. Well, you said it. You said it. I didn't. I was biting my tongue. I think as closely as you can approximate the Hill Center classroom. I think that who was it that said, I think James Comer, I think he was the head of the education department at Yale, something to the effect of without a significant relationship, there is no significant education. So I do think a teacher that is warm, caring, and firm
Mhm,
is the best teacher.
mhm.
And if the classroom size can be half of what they are currently, I think that would be ideal, although I think even, smaller size than that would be the ideal.
Yeah, absolutely, absolutely.
I do think the teacher makes, again, I don't think the teacher causes ADHD.
Sure.
But I think careful attention to teacher placement is really important.
Agreed. I want to end with you maybe tossing out some possible career opportunities that are well suited to people who have ADHD.
That's a good question. I will think through the folks I have worked with.
Okay.
So I think I've had a fair number of physicians, a fair number of other medical folks. I've had a really striking number of folks who are entrepreneurial, who have made gazillions because of their quick thinking and their desire to risk take. So I think I know one young man who's one of the top real estate salespeople in the state, if not the Southeast. Depending on how much of the hyperactivity part, I think you don't need to be sitting behind a desk. You need to be up and moving around, whether that is, coaching or, I've seen many good teachers with ADHD. Who got help with their organizational skills, but they were phenomenal teachers. I think something repetitive is probably not going to fit the style of an ADHD combined type person.
Yeah, I told you that was going to be the last question, but I have to do this one because Sandy, if you're still out there, you have been incredibly patient. But Sandy is interested in learning more about the driving. What ways does ADHD affect driving with teens? You mentioned that it can
makes
be
them go faster.
Yeah.
Makes them go faster, makes them not pay attention to stop signs. Makes them not pay attention to looking on either their rear view mirror or their are paying attention to any alert that there's someone in the other lane that they're trying to merge into. If there are other students in the car of their same age, they're not going to be focused on their driving that much, and I would certainly limit. And cell phones or mobile devices, whatever you want, smartphones are have added a new level of risk to driving, even for people without the diagnosis.
Well, Dr. Riddle, I am going to echo Deborah's comment. She says, thank you so very much for your expertise. And we thank you as well.
It's been a fun evening.
Good. I'm glad you enjoyed it. We did as well. And I know a lot of folks, based on what I'm seeing in the chat and my own experience tonight, got a lot out of what you shared tonight. And,
good.
you know, I know you could talk about it for hours. I could listen about it for hours because it's so impactful to so many families and kids. So thank you. Thank you. Thank you.
Yeah,
it
you're
was
welcome.
fantastic. Really appreciate it.
All righty.
Thanks. All right,
All
everyone.
right.